Thank you. Thank you for being here. And it is truly a privilege to have an opportunity to have an hour with these outstanding leaders for our community that are truly committed to creating systemic change so that we can reduce existing inequities and disparities that in terms of maternal health. But I know you also wear multiple hats. So I'm Dr. Luz Garcini, Interim Director of Community and Public Health at the Kinder Institute for Urban Research. And with me today, I have the privilege to introduce Dr. Marlen Trujillo. Dr. Trujillo is the Chief Executive Officer at Spring Branch Community Health Center, the original faith-based charity clinic that you helped found back in 2002, but that now spans several clinics around Houston. It was designated as a federally qualified health center in 2005, and Spring Branch Community Health Center provides quality, affordable healthcare services to underserved and uninsured communities. Next, we also have Dr. Esperanza Hope Galvan, Vice President of Harris Health System, the public healthcare safety net provider for residents in Harris County that focuses on low-income, uninsured, and underinsured patients through acute and primary care, wellness, disease management, population health, and correctional healthcare services. Characterized by an unwavering commitment, Dr. Galvan's leadership is focused on optimizing healthcare delivery systems and driving care transformation by applying data-driven methodology to inform population health. And then we have Dr. Charlene Flash. Dr. Flash is the president and CEO of Avenue 360 Health and Wellness, a 7-site health system in Houston that provides care while addressing social determinants of health for marginalized communities, regardless of patients' ability to pay. Dr. Flash is an infectious disease physician and voluntary faculty associate professor at the University of Houston and Baylor College of Medicine. So thank you for your leadership. Thank you for being here and for the opportunity to learn from your voices. So this is just a conversation, a panel discussion, so that we can learn from each other. We can learn what can we do as scientists to address the real needs that they faced on their everyday lives. So my first question is going to go to Dr. Trujillo. So what is the current state of maternal health among historically marginalized communities? What communities are most affected, and what inequities and disparities do we currently face in terms of maternal health?
So in my space, I run the Community Health Center in West Houston. So if you're familiar with Houston, we're along the I-10 Katy Freeway, 610, 290, everything from Spring Branch to Cy-Fair, Katy, and kind of that corridor of Bear Creek area. But the population that we're serving is about 89% Hispanic, Spanish speaking. So in our space, we're seeing a lot of women who are coming to us continuously needing women health services, but primarily in the prenatal care area. We're starting to get a lot more individuals coming into this country. We're seeing individuals that are uninsured and don't have the care that's needed to take care of their pregnancy. So they're coming to health centers like ours. So I think in our space, just the lack of understanding on how to navigate our system, healthcare system, and knowing that there are faith-based organizations, health centers like ours in the Houston market, that education component is really lacking among those newly arrived individuals in the Houston area. So we're trying to do everything that we can to educate them. But I would say that's a primary need, is just the education and the access to those women that need our support, because they keep coming to us at 34 weeks, 36 weeks, and it's kind of a little bit late in the pregnancy. We're still providing the care, but they start becoming a high-risk patient for us.
Thank you for that perspective. Dr. Galvan and Dr. Flash, would you like to add anything else as to what have you seen in your organizations and in your expertise in terms of the challenges that we're facing in maternal health?
Yeah, so very much what she said, I echo the same. I think for our organization, being a safety net, and I heard somebody say earlier, trust, the community that we serve, of course, I have 50% uninsured, and most of our patient population also Hispanic. I think that the barriers and the challenges have been created through a lack of trust with a healthcare system that we're working really hard on. But also, too, is that our community, I mean, Houston is so big that we set barriers for our patients sometimes because we are not really putting, sometimes, historically, we've never put clinics in the right areas, looking at just geographical spaces. And so I think that sometimes it's a little bit of everything, right? From the patient population that we serve, being able to meet their needs, but also what we are doing as organizations. But again, the future is bright because I feel like we're in a new wave where data is driving a lot of our brick and mortars, as well as the interventions that we're providing.
Thank you for bringing that. And I appreciate you bringing the point of trust, because as I was here in the prior presentation, one of the things that we constantly hear from the community members is, I don't want to be monitored. Where is my data going to go? Who is going to be accessing that? Is this rhetoric going to harm our communities even more? So Dr. Flash.
You know, when I think about the challenges of maternal health in Houston and in the underserved communities we serve, it's useful to think of it in its larger context. As I was listening to the last presentation, which was excellent, talking about what's happening in developing regions, I was reflecting that there are some zip codes that we serve where the maternal child health outcomes rival places outside of the United States. And so particularly amongst the populations we serve of Latin women and African American women and their babies, the challenges that we face are that these babies are more likely to be low birth weight. These moms are less likely to have full prenatal care. They're more likely to have pregnancy-induced hypertension or have complications like abruption, et cetera, and the list goes on and on. And so when you think about what we're doing, and we're all kind of sitting in it, so sometimes we forget about the larger context, that there are zip codes in Houston, in Texas, that have some of the worst maternal child health outcomes in the entire country, and in the areas of development within the Western world. And so that's a huge problem. So that's the context in which we're working.
Yeah, thank you for also bringing that up, right? Sometimes we tend to see marginalized communities. You know, I have the privilege of working in the border in tent encampments, but we don't have to look that far. We have them in our own backyard. And sometimes we tend to forget about that. So I appreciate your perspectives on that. My next question is going to go to Dr. Galvan about the role of science. So what is the role of science and scientists in addressing maternal health inequities? How can scientists support your efforts, the things that you're seeing, and contribute to systemic change?
Yeah, thank you. So I made myself notes, not because I'm going to read, but because when I saw the question, it was just like, oh my God, this is fabulous. So I've been a nurse for over 25 years, and I'll give you several different perspectives. Being somebody at the bedside, always in a hurry, trying to treat as many patients. When I started nursing, I was in South Texas, 8 patients to 1 nurse. Moved to Houston, 6 patients to 1 nurse. I know it's gotten better now. When somebody from science came in, it was like, unless you can do what I really need you to do for me, we don't have time, we're busy. And it's like, oh, here comes somebody else who's trying to, you know, no offense, I'm a PhD, get a dissertation, right? But it was really a struggle, right? I mean, we knew it was value add, but it never felt like they were actually coming into our system to really, you know, work with us. And so the value of science is critical. I mean, I feel it every day firsthand now, because as I have created the food pharmacies at Harris Health, they've only been sustained because I've collaborated with, you know, UT School of Public Health to help me put evaluation into it, to help me show our executives who are also dealing with other bigger issues, trying to keep up buildings, build new hospitals and things like that, that this is value add, and that this addressing health-related social needs will impact length of stay in the hospital, will impact the utilization of your clinics, will impact all, you know, your nursing satisfaction as well as your physician satisfaction. So from that perspective, I tell my team all the time, it's like, who are we partnering with to help us demonstrate this success? You know, us nurses and us physicians, we're in it for the right reason, but when you're busy and you're having patients who come into a safety net who are train wrecks, right, for the most part, because they're uninsured. We have to work with our partners to be able to demonstrate that return on investment, to demonstrate what are some of those outcomes. So yeah, it's critical.
Yeah, I appreciate your comment because you have the boots on the ground. You know exactly what that looks like. I had an interesting few minutes exchange with Dr. Trujillo as we were hearing the prior presentations about problem solving and teaching them how to fix the machines. And then she looked at me and she's like, there's 100 line waiting. They don't have the time to problem solve. They cannot go and address the machine. They need to call a company and do it because the lives are more important, right? So Dr. Flash and Dr. Trujillo, what do you think what can science do to help you?
So I think there's a lot of interesting challenges when we think about it. So first, just to define terms. When I say underserved, sometimes people hear poor, uninsured, or immigrant population. But when I say underserved, I'm also talking about people that kind of look like us, right? I'm a mom, I have 3 children. I also have 3 degrees. And I had complications in all 3 of my pregnancies as a Black woman, right? And so I'm a statistic in that sense, and there's no reason for it. I'm a physician, trained in adult medicine and pediatrics, and board certified in infectious disease, but I had that experience. So some of the things are to ask those questions, which are the uncomfortable questions, about what was happening there, and so why did this demographic experience this poor outcome or this complication or this fetal loss, and this population did not. The other place is for science. I think you mentioned it really nicely, talking about the challenge of when the scientist sits at the table and comes up with the idea, as opposed to having a more participatory engagement with the community where there's a season of observation helping to identify, well, what are the problems that you see and what are the key elements that you've already identified? Now go to the table and say, well, what are some potential solutions? And then testing the acceptability of those solutions iteratively so that there's more of a partnership. And I think that community health centers would be more excited to come to the table to talk about what the challenges we are and to iteratively test things. It's not exciting when you say you're doing something and now 7 to 10 years later, you're gonna come back with whatever the patent is. That's not gonna help the woman who's in my office right now with this challenge. And so implementation science, community-based participatory research, things not being scared of the hard questions like racism, unstable housing, food insecurity, these big societal issues that seem overwhelming, but scientists can figure this out. We have faith in you guys.
Thank you. Beautifully said. I think it's so important, the co-creation of knowledge from the very beginning as partners, as having you at the table together with our science to build that technology, to create that technology, to use it, to implement it, right? What works, what's not going to work is key to make it efficient and effective. Thank you. Dr. Trujillo.
I think I would just add on the science part, we need to make our providers more efficient, and I don't know how to do that when there's a human aspect to it, to reviewing labs, to reviewing examinations. They only have so many hours in the day. I'm not a clinician. I would love to put the white coat on and help them. I speak Spanish, but I can't help them. So I can't help them move any faster. All we can do is improve check-in, improve the wait times in the lobby. We can improve the registration process, but during that clinical component, which is, their face-to-face time with the patient, are there any technologies, are there any instruments that we could make the visit much faster and have those results ready, have those conversations before they walk in? Is there any technology available for that? On mobile health clinics, is there anything we could do by taking instruments into the community that could produce some faster results? Maybe it doesn't give the final solution, but at least it gives us a kind of a preview to them before they walk into our clinic and spend another 45 minutes with a physician. So I think there's a lot of movement going on. I know we're not talking about AI, but there is a lot of movement in AI that is helping healthcare and really at the community level, because we have limited resources, and the faster and quicker we can get patients in and out, the more funding that can come to organizations like ours that are really focused on fundraising, and if we don't have any margins, we really can't follow our mission.
I'm so glad you're bringing AI to the table because we hear so much about that, right? And on one hand, we hear that it's going to help meet some of the need, but then on the other, in the back of our minds is like, well, who is informing the AI initiatives, right? Who's developed the algorithms that we're using? And I think that's the part where if we don't have you and your communities at the table, then it can create even wider gaps or wider disparities and a lot of risk. We know that people of color do not receive the same quality of care. So what are your thoughts on AI in terms of how it can be used to address maternal health?
In our space, what we're doing is trying to mine the data, if we can call it that. I've got some great individuals on my team on the operations side and the information officers that are constantly looking at data and quality metrics in order to focus on more meaningful use and value-based care. So how we do that is looking at the metrics. So critical labs, how quickly can we return a phone call in our health center? If you get labs today, you get labs in 3 to 7 days. How quickly can I get that result, that phone call? Does it have to be a human person? Can it be an MA? Can we have standing orders? Again, I'm not a clinician, Dr. Flash. I just have ideas, and our staff is like putting things together, and I've got MDs that are saying, no, we can't do that. We can't trust the technology. We can't trust those robots. We can't. But there has to be a bridge and a collaboration and, like you said, a co-creation to these systems because I think there's value in them. Our staff are overworked. They're burnt out. They want to leave healthcare. They want to work 3 days a week. They want to have Fridays off. Well, how do you manage that with a busy schedule? And like you said, you have 100 patients in line waiting to get seen. So I think there's still opportunities, and we're still learning a lot.
I think you said it best, right? I'm all about AI. I know at my organization we're probably a couple of years behind, only because we're strategizing all of that right now. But I think that if we have the right support, right, at different levels, from organizations to regulations and what have you, that really put a voice behind that AI, that is not just created so far away from our patients, so far away from our organizations, and they just feed it to us. I think it's exciting. It's really exciting. But I will say that I think from my perspective is really putting that, whose voice is behind that AI? What does that picture look like?
What do I think about AI? So that's an interesting question. I will share that I'm fundamentally a technophobe. I walked up here with my paper, left my phone in my purse. And I think that it's hard to say you're behind the curve, don't feel badly, because 3 years ago it wasn't there, right? But what I think about it as I've started to, as a leader of a healthcare organization, I said, okay, I'm gonna have to figure out how this is going to help the organization. And what I realize, or what I'm learning, is that the model feeds itself based on what users put into it. And so if there probably is something about my first generation immigrant Black woman upbringing that feeds my technophobe element. But if I don't engage with AI, then the model will not be fed with the questions, perspectives, and challenges that someone that has walked my walk has. And I don't know that we've spent the time to make sure that the diversity of the community understands that it's as important to get things out of AI as to ask those questions, because it actually, from my limited understanding, I found it curious, and so I kind of started to try to understand how is it generating knowledge. And I thought, this is a potentially extraordinary tool, but if it keeps learning in this funnel, then there will be this entire segment of society that's left out. And entire segment of how problems are solved that are left out. So sometimes I was writing a presentation, and so I threw in one of the questions, and it was fascinating the way what its perception of social drivers of health was, right? And so I said, oh, this is a fascinating question. I wrote what I would have said, and then I pushed it in and said, what would it say? And I said, this is fascinating, and you can tell, you can see it. If you ask these types of questions, you can see where there's just interesting ways that the questions are populated, and then it feeds it back. Now, in medicine, it is potentially incredibly powerful, but much of science, much of the medical science, and I'm speaking as a clinician and as a researcher, it's challenging, it is more challenging to recruit people from marginalized communities and define margin as broadly as you wish. And so the body of literature really is talking about white men. And when it's talking about women, it's excluding women of childbearing age because everybody's scared to do research on women of childbearing age. So the questions of this conference, there's actually very limited diverse research in the literature. So when you dig into AI, if you throw it in, you have to say these studies weren't about the women that we're talking about on the stage here that are coming to community health centers. And so there's some computer science thought leadership that's not going to come from me that needs to go into how do you fill in those gaps and how do you maybe oversample from a more diverse study populations so that the outcome really reflects the population that we're serving here. I don't know. It's not my area of expertise, but that's my opinion about it.
Thank you. And your opinion is so on target of what we keep hearing from the community, right? So we know that we're facing big challenges, and we know that there are existing disparities and inequities that are affecting maternal health. So let's move on to solutions. So in your view, and I'm going to start with you, Dr. Flash, in moving to solutions, what practical or tangible steps do you think are needed to reduce and ideally eliminate maternal health disparities and inequities in your communities or in marginalized communities?
So from a solutions perspective, first I'll share that the core challenges are, one, the existence of disparity, and then for our population here would be housing instability, accessing care at the appropriate stage in the prenatal time frame, and then access to mental health services, and then understanding how to engage with healthcare would probably be the key areas. And so when we're thinking about solutions, we start with the problem statements in mind and try to understand, well, what's different about this population, and then how do we tailor the solution to the needs of this population? Is it the language barrier? Is it the building of trust? Is it the needing to understand the technology that's going to be used and why so much blood is being drawn and why so many visits are needed and why I have to wait for so long for these visits? So the solutions have to be stratified by the different populations that we're serving. When we think of housing instability, though we have a housing program, we can't house everyone, and so trying to shift our models of care such that you can still provide care even if someone is in an unstable housing environment. So when one of the presenters said, well, this is for the developing world, and I said, actually, no, that would be very cool for us to be able to have these women who are unstably housed here be able to be monitored. And in terms of building trust, it concerned me that we thought it wasn't a good idea to somehow let the mom be able to know when something's actually wrong, right? Because we have to engage with communities and we have to be honest with them. It drives medical mistrust when we try to protect people from their information. It's better to place the information in its context. So the solutions are, one, engaging the community, curious and stratifying the data by the populations that are having the greatest need. If you can't house everybody, you have to figure out how to care for them even when they're unstably housed and moving from cousin to cousin or under a bridge or wherever they are from that perspective. Figuring out how to stabilize mental health even for people who don't want to go to a mental health provider because of whatever stigma is associated with that. But there are models of care like group visits and centering and things of that nature that can kind of get to the mental health stability without the person going to the psychiatrist that they think is saying that they're crazy, right? From that perspective. And then also the food insecurity piece is also an important place to partner and to make sure that that mom and that baby are getting adequate nutrition.
Yes, thank you. So important to mention the focus on the social determinants of health and the focus on holistic care, right? We tend to forget we cannot treat physical health without mental health. I mean, they go hand in hand, particularly for these communities. Dr. Galvan and Dr. Trujillo, would you like to add as to what are the steps, what solutions do we need to begin to move towards health equity and social justice for these communities.
Yeah. Full disclosure, I live in Utopia General, and I work there too. And I say that because I agree with everything that you said. I think the opportunities, and this is what I face a lot, is that when it comes to partners, I always feel like the first thing that's being told to me is, well, they're kind of our competitor. It's like we don't compete. We're in healthcare. Healthcare, there is no competition. Some of my patients may go to her, some of them may come to us. What I'm excited about is the future, because there's very little things that the Center for Medicare and Medicaid, bring down to a healthcare system that you get excited about. From my perspective, I was very excited about the screening that we were mandated to do in a hospital. I know it's probably a little bit reactive and a little bit much for some folks, but from my perspective is the patients, when they come into us and visit our pavilions, whether it's our clinics, whether it's our hospitals, that information helps us. Imagine the world where our patients will come into the hospital, come into the clinics, where they see that when we screen for health-related social needs, it's a part of their care plan. It's not because we're going to report them. It's not going to be because, why are you asking me, are you taking my children? Because you're asking me all these questions. But it's going to be part of their care plan. Now, what I imagine is because this is knowledge, then I hope that with my partners who are out in the community, when my patients come into the hospital and I see that they're in her zip code or her zip code, to be able to share the information that says, hey, Dr. Flash, I'm seeing this in your zip codes. I don't have any clinics there. Or I do have clinics, but they're very specialty, and I need you or your support in primary care. What does this look like? In a very partnership, collaborative way, where we're both getting our strengths, working off of our strengths, I should say. And so from my perspective, it's having that data that we can share because we're serving the same communities that we can learn from, and then you put the science behind it, right? Because we're all very passionate about what we do, but unless I have the science support, you think policy is going to change because Hope Galvan says that food insecurity is exciting? No, it's going to be the science behind it that says we work together, you helped us with the evaluation, you took it to the next level, now where's change? Now, again, I'm in Utopia General. Right now, it takes too long. We've got to move this faster. So that's my solution, maybe?
So my solution is very similar to Dr. Galvan's. We have the best medical center in the world, I would say, and we have a fragmented healthcare system. Our healthcare system in Houston is not the best. And if you know anything about healthcare, and if you don't, I'll give you the 101 version in a couple of seconds. We have the hospital system. We've got Harris Health, part of the county. We have Harris County Public Health, which is another part of the county. We have the City of Houston Health Department, all of them with big, big budgets. We've got the FQ8Cs, and I think now we're at 14 FQ8Cs, federally qualified health centers in the Houston area that bring federal dollars into the city. And then you have the additional safety net clinics, which are the faith-based charity clinics that bring in a lot of private dollars. We don't work together. We don't. That's a huge problem. It hasn't been fixed in 20 years. I've been in the system for 20 years. We're making improvements, and unfortunately, we get leaders who start. Beautiful vision. They leave. They're pushed out. They're terminated. We have to start all over. So I think the solution to our healthcare issues in Houston, to getting some of these people the need that they require in healthcare and improve the health and make healthier communities and build systems of care, we have to be able to coexist in this community together and be able to work together. Like you said, not as competitors, as partners, collaborators. We don't have to share money. We can collaborate together. And I think there's a lot of work still to be done in the Houston area. The funders, certainly the philanthropic community in Houston is very given, but they also have their pet projects. So they'll drive what we do as organizations because we're chasing the money. So I think there is some positive, future thinking. I think there is some change coming. I can feel it a little bit different than 10 years ago. But I think it has to start there. It has to start with not everyone needing to be the chief, not everyone having to get the brownie points, not everyone having to get the spotlight, but how do we do this together? And the ultimate goal is to increase the healthcare status of our community. And it can be the Asian community, it can be the Black African American community, it can be the Hispanic, it can be the Anglo, it can be all of it collectively. But we have to learn how to coexist and work together. You said it earlier, co-creation together, and I think that's a big part of it. So I think solutions are needed there at the very, very top.
Thank you, Dr. Trujillo. And I think, that part of how do we start building alliances, right? How do we start collaborating across the centers? And I think that is where the hope for those scientists out there, right, in the audience, this is where we can come in and bring the science, do perhaps those grants that are also going to benefit the community to build a unified mission, because when the community feel invested in a project, right, that we can see, okay, this is leading to something at the same time that is bringing money to create those changes, that's when we can create the systemic change. So I want to leave questions for the time for questions for the audience. So I'm going to ask you all one last important question. In this room, full of innovators, if you could wave a magic wand, so pretend that you can get anything that you want, what do you want in your hand to help serve your constituency more effectively? I start with you, Dr. Flash.
What do I want in my hand? I want help. I say that partially in jest, but I wasn't going to say this because almost for me it seems obvious, but I would share this. When I joined the agency that I now lead in January of 2020, and I engaged on a journey of curiosity to learn. And so I went from location to location and employee to employee and spent some time and stood next to all 200 employees, spent some time next to them at the point of where they were working, from a space of curiosity to understand what their work was like and to see what the barriers were. Because what I realized is that sometimes when you've been working in dysfunction for so long, you're doing weird things like, you're cutting the napkin in half instead of going across the hall and take those tissue and use that, right? Or whatever the problem is. And so I think that if I had a magic wand, I would say that for innovators, I would love, instead of feeling like innovators are taking from us, for them to come in and help us problem solve, walk along the journey with us and look at it with clear eyes. My favorite thing to do is actually to bring other people on that journey with me, because when you bring an engineer or a shoemaker in, they see things differently. They're like, how come they waited 20 minutes for that? Why don't you just let them, go wherever they are and you let this thing beep and then they know their appointment and they pop upstairs for that, right? So there are all of these things that are outside of the way that healthcare generally works that create innovation that is not incremental. It bends the curve. So I think that if I had a magic wand, I would want help and I would want curve bending solutions. So I don't need little things where we just sit in a room. I need you to come and look and say, and tell me, well, what do you see? And what are your questions? And then let's figure out together what potential solutions might work.
Beautifully said. Dr. Galvan?
Yeah. Working in a safety net, I agree. Help. We need help. I think if I had a magic wand, I would love to be able, and again, this is probably a little bit clinical of me. I would love to have health-related social needs screening that is standardized across everybody using the same tool. Because everybody in here at one point in your life, if you haven't yet, you will go visit a hospital, a clinic. You will. And imagine that no matter where you go, the same questions are being asked. And then we can share that information to really add it to the care plan to say, instead of just telling Mr. Galvan, here you go, here's your medication, we're going to give you the best procedure, be able to understand his life system and be able to make sure that what we're recommending, that he's being set up for success, and that it's not just a you should, you need, you must, right? So again, Utopia General, standardized screening, that would really inform us, because we're all in healthcare. If you're not visiting, consuming it as a patient, you're working in it, or at one point in your life, you'll be doing both.
Dr. Trujillo.
So my little magic wand would produce tons and tons of cash in front of me, like right now. I'm basic. You have cash, you've got resources, you can make anything happen. So I'd encourage to, I guess recommend or invite you to invest and spend some time at the grassroots level of healthcare. Not enough money and dollars are being thrown into primary care at the local level, at the community health level. I know it's not sexy to take care of diabetes. I know it's not sexy and exciting to take care of hypertensive population, but that's where the dollars are needed, not the dollars that are going to the shiny buildings in the medical center or the shiny buildings in West Houston that are going up in beautiful hospitals. Yes, we need that too, but not enough money is invested at the local grassroots level. And that all helps the ecosystem and for us to be around healthier people. So that would be my solution.
Thank you. That was great. So I first of all, I want to thank you, but I want to open it to the audience to see if you have questions for an amazing leaders. Go ahead.
Yeah, I'm an engineer. I just founded, medtech company last year, mainly focused on pediatrics. And I just learned 50% of children in the United States covered by Medicaid. And I start to study that, as you mentioned, right, United States, but we still have the low resources areas. I started to study the Medicaid. I found that there is no coverage for rural area. I don't know what kind of options for those, population. You probably have more insights than me. I don't know those, answers.
Yeah, so you've stumbled upon Texas's dirty little secret. We have the highest rate of uninsured in the entire United States. And that disparity predated the Affordable Care Act and the Medicaid expansion. And we are now one of few states who did not expand Medicaid. And so the disparity between the proportion of the population that has healthcare coverage and those that do not has only widened for our state as compared to the rest of the United States. We here on the stage are part of the solution because we are able to bring federal dollars into the communities and use those federal dollars to support the health care of unfunded people based on their household income and their family size, utilizing a sliding scale that's subsidized by federal dollars. However, the amount of space and capacity and efficiencies that we have does not fill the gap of the millions of people in this region who do not have any coverage. And even in the midst of this, there are many people that you don't even have to go to that rural an area. You just have to leave Harris County. We are blessed to have Harris Health System fill in gaps in terms of trauma, hospitalization, and subspecialty care. You can just go to Fort Bend or to Livingston, or just go one county over in whatever direction you want, and those resources no longer exist. And if the person lives in that jurisdiction, they don't have access.
Okay, so thank you. My company is called KTAG, so I probably just reach out to you then. Thank you.
Thank you. Next question.
Sure, thanks. Deborah Mansfield, and I'm part of the innovation community here in the Greater Houston area. So I know we have a couple of resources that maybe you can comment on per either the use of data or with respect to the social determinants of health. So we have the Greater Houston Health Connect, which is involved with the electronic health records. And I don't know what the movement is going for, how they're using all of the data that could potentially come out of that respect, either with the social determinants of health. And then the other one maybe that you could comment on is the new Texas Non-Medical Determinants of Health Consortium and how they're trying to work towards, I think, what you had mentioned about standardized approach to these determinants. So if you could maybe help us with some of that information from the Texas perspective. Thank you.
Yeah, so the consortium, we work with them very closely, and they've been a great facilitator, great connector, and I love that they kind of have tentacles throughout the state. I've actually work with them as far as food insecurity, and then that they also have a repository of all the different interventions across the state that are dealing with food insecurity, and there's so much work going on there. So we're there with them. With the Greater Houston Health Connect, I will say that in healthcare, because we have all of these different regulatory data rules and what have you, we're looking into how do we work closer with a HIE. But right now, we're not working with them directly, but we do talk to them. We look at like, what does this look like for in the future? But that's where we are with them.
So on the Greater Houston Health Connect, they've been around for at least 10 years. We've been a member, but you have to pay to play. So if a health center patient of ours walks in and they said, I was at Memorial Hermann West, Katy campus on Saturday, well, we need those records. We want to see what the doctor, in the ER did. Let's catch up. Let's download the records. So it allows us access if they're participating in the Greater Houston Connect network. We're participating, but again, you have to pay to play as a member. I think y'all are too.
So I would say that when you look at the Greater Houston Health Connect, and I was engaged with it when I was at Legacy Community Health and now at Avenue 360 as well, that I think the quality of the data has improved over time. From the physician side, like when I go into to try to see what I can pull out, it has improved over time. I think it's almost the question should be in reverse. They are connected to all of these organizations. Other than data sharing to enhance the point of care for the patient in the room, how is that data being used to elevate the population health? I don't know that that's happening. Maybe it is, and I'm just not aware. But I know that at the point of care, when I'm in the room and seeing a patient, I can utilize it. But as the CEO, how is that information coming back to say, this is what's happening in your health system or in your region, and this is how you should shift resource allocation to respond to that need?
Thank you. So I want to be respectful of your time and of our panelists' time. So perhaps we have time for one more question.
Hi, great talk. Very inspiring to see a group of women dominating, so thank you. I just had a question about what do you think the role of policy has to play in addressing these healthcare gaps? Because I know we've talked about clinician work and technology and how that interacts, but what do you think about policy?
I might get fired today. I'm very opinionated, very direct, if you don't notice by now. A lot, it's very important. Luckily, the federal system on the federally qualified health center side, we have great bipartisan support. We have to, speak to our Republican elected officials, and we have to speak to our Democratic elected officials. But we have great support for the work that we're doing in the community health space. There's no doubt about that. Where we continue to do work and focus is on advocacy. How do we put more dollars into the federal community health center program? That hasn't happened in years and years and years. The most funding we've received, just for full transparency and for data facts, during the Bush administration, there was a push for community health centers. We got funded during the Bush administration. During the Obama administration, we got extra dollars to expand capacity, add more clinics, put more services. Since then, there has been not much. We're barely now starting to see expanded capacity access for mental health, for extended hours, for new clinics. But the baseline of additional dollars for opening up a new clinic continues to be the $650,000 seed money that we received in 2005. It hasn't changed. So advocacy is needed for continued support in the community health primary care space, but more dollars to increase what we're doing because there's such need in that space.
So policy. So we need Medicaid expansion in the state of Texas, period, full stop. And it is almost a dirty word to say that when you're talking because it has become so politically inflamed. I moved to Texas from Boston, where the Affordable Care Act was Romney Care. Romney is a Republican. This is not a Republican or a Democratic issue. This is about access to care. So we need Medicaid expansion. We need housing dollars. We have a housing challenge because we choose to have a housing challenge, and we choose to put those dollars towards people who've been on the street for about 2 years before we start to help support them. We need short-term rent, mortgage, and utility assistance to the person who comes and says, I haven't made my rent for 3 months, I'm about to get evicted. So that we could stabilize, we can plug the hole so that we don't keep pushing people out on the street. We need dollars for substance use recovery and fentanyl test strips. These are things that are not able to be accessed here in Texas, and it doesn't make any sense because the opioid challenge is actually rising in our jurisdiction. We need clinical infrastructure dollars for safety net, that if we're not going to expand these payers, then expand your safety nets, but you can't choose to not do both. It doesn't make sense because the enemy or the competitor isn't the other institution. The enemy is poor health and dying moms and babies.
Thank you.
I think I wanted to just end with just saying I'm a realist, right? I know I've said some things about my utopia general, but honestly, I think that healthcare for many years has been expected to do better. We have quality indicators that say, check hemoglobin A1Cs, check blood pressures, your patients are not well controlled, they're coming too often to the hospital. All of these clinical indicators that we get blamed for, because that's really what happens, right? The physician who's there, it's like, you've got to do better. You're not prescribing, you're not doing this, you're not. And there's this whole factor that affects us personally in healthcare that we have to take a second look at, right? Because with the health-related social needs screening that I talked about, is that it will give you information as to really what is happening in your patient's life system. Whether you're a CEO or whether you're a VP, whatever role you play, you will be able to see what is really in this patient's life system that impacts them having to take their medication or not being able to take their medication, not being able to get to your appointments. Quality indicators that are used in healthcare. So from my perspective, it's gathering that information that is unified in a partnership effect that we can together make the ask for policies as this is why we need more money. This is why we need more clinics in the right locations, and this is what's impacting the patient. So that's what I hope to see one day. Maybe I won't, but being so many years in clinical practice and being a nurse, those are the things that we're not addressing, that no matter what best prescription or best procedure we get or what top-notch doctor we get into the health system, at the end of the day, it's the patient's life system that we're not considering. And so we need the community partnership, and we need the science behind it. So.
Thank you. Thank you for the three of you for all of the work that you do in the community, for being here. And thank you. And please welcome me and join me in giving him a big round of applause.